Hello everyone, I am Madhavshin from IGCP and I warmly welcome to all our esteemed doctors and participants for today's IGCP webinar. So session focuses on one of the most technically demanding and rapidly evolving procedures in gastrointestinal surgery, minimally invasive Whipple's procedures. Where do we stand? So the Whipple's procedures or the pancreatic duodenectomy remains a cornerstone of surgical treatment for selected pancreatic and periampullary and duodenal malignancies. Traditionally performed as an open surgery, advances in laparoscopic and robotic techniques have made minimally invasive Whipple's procedures increasingly feasible in experienced centers. While these approaches offer potential benefits such as reduced blood loss, faster recovery, and shorter hospital stays, they also present significant technical challenges and require careful patient selection, advanced surgical expertise, and multidisciplinary collaboration. Today's discussion will explore the current evidence, evolving technologies, and future direction of minimally invasive pancreatic surgery. To guide us through this important topic, we are privileged to have with us one of the most India's leading gastrointestinal and robotic surgeon, Dr. Deep Goyal, sir. So let me share some of his achievements with you all. Sir did FRCS from England, FACS from USA. Sir is the President-elect and Indian Association of Gastrointestinal Endosurgeons. Sir is the Chair and Health Division of Bharat Society of Innovations and Startup. Sir is the Vice Chairman in the Head Department. Sir is the consultant in robotic surgeon. Sir is in the Department of Surgical Gastro-Oncology, Bariatric and Advanced Minimal Access Surgery in BLK Super Speciality Hospital in New Delhi. Dr. Deep Goyal sir is a renowned gastrointestinal bariatric and a robotic surgeon with extensive expertise in advanced, minimally invasive and a robotic gastrointestinal surgery. His contribution to surgical innovation, education, and research have played a significant role in advancing minimally invasive gastrointestinal procedures in India. So, it is a privilege to have you with us today, sir. On behalf of IGCP, I extend a warm welcome to you, sir. Thank you so
Thank you
much
so
for
much.
joining, sir. Yes,
Thank you,
sir.
Ada, for a kind introduction, and I must thank IJCP for giving me this opportunity. And as you already said, that pancreaticoduodenectomy is one of the most complex and challenging surgeries in general surgery, and minimal invasive surgery has actually revolutionized the way we do these surgeries. And today we're going to talk about something about the disease itself and the procedure and how we do it by robotic surgery. Thank you.
Okay. Shall I share your
Can I
screen,
have?
sir?
Yes, please. Yes,
Okay.
please.
Sure, sir. I'm sharing.
Okay, so this is what we will cover in today's talk. Yeah, next slide, please. Why minimal invasive ripples? How do we decide resectability? What are the standard steps? What are the learning curves? Robotic versus laparoscopic, oncological clearance, and anastomosis. Next slide, please. So when we say resectable disease, what we mean, you can see this, this is the tumor in the head of the pancreas. These are the major vessels like superior mesenteric vein, superior mesenteric artery, portal vein behind the neck of the pancreas. And if the tumor is involving these vessels in various angles, that is how we decide the resectability. Next slide, please. You see this? If it is only abutting less than 90 degree of the angle of these veins or major vessels, it is considered to be resectable. Next slide. If the tumor is involving or encasing these major vessels or involving more than 180 degree of angle of these vessels, then they are obviously not resectable. Next, please. If the angle of the vessels is more than 180 degree, as I said, or it is encasing the celiac artery, then we mostly believe that this is an unresectable tumor. Though one can argue that we can reconstruct these vessels, but at this point of time, we consider them to be not resectable. Next slide. So this is how pancreaticoduodenectomy looks. If you see the dotted line, red lines, this is the part of the GI tract which we remove during the surgery. Head, part of the neck, part of distal stomach, common bile duct along with the gallbladder, and some portion of the small intestine. Once you have removed this, this is how we reconstruct. We take the loop of the jejunum behind in a retrocolic manner and do a pancreaticojejunostomy, hepaticojejunostomy, and gastrojejunostomy. And so the food comes from here, comes to the jejunum, and goes down. And the bile comes from here and goes down. So this is how reconstruction is done. And that is where the complexity happens. So complexity happens in two places. One, while we are removing the uncinate process from the major vessels and while we are doing reconstruction. Next slide, please. So let me take you through the steps. Step one is exposure of intrapancreatic superior mesenteric vein, and this happens after cauterization. This is the superior mesenteric vein, this is the duodenum, that's the pancreas. This is the large bowel, right side colon. Next slide, please. And you will reach this place after cauterization. Cauterization means, you see this, this is the duodenum which was lying like this, like a book, and after mobilization we have flipped a page, and this is what exposes the IVC, superior mesenteric vein, and aorta. This is what is important. These are the renal veins, and these are the landmarks that once you expose the vena cava along with the renal vein, that is when you know that your dissection is complete or cauterization is complete. Next slide, please. Then we do portal dissection. All the tissue around the portal vein is dissected out. Next slide. Then we divide the stomach. So we have dissected the portal vein. Around the portal vein, we have disconnected the common hepatic duct and we have disconnected the stomach. Next slide, please. And next step, we will do cutting of the pancreas. Or what we can do is we can transect the small bowel around the ligament of Treats. You see here, and you take everything on towards the right side. So stomach and this cut jejunal part goes towards the right side of the major vessels. Next slide, please. And once you do that, we cut the pancreas at the neck. And this is the portal vein and superior mesenteric vein. You see here, that's the cut end, distal cut end of the pancreas. This is the pancreatic duct. Next slide, please. So this is the critical step which I was talking about, that ligament of Treats is taken and dissected out. Next slide, please. You see, this is called the mesopancreas. And small vessels are going through this. We need to dissect and ligate and disconnect the uncinate process from the major vessel. Next slide, please. And then starts the reconstruction. So we do pancreaticojejunostomy. This is mucosa to mucosa anastomosis most of the times. Then we do hepaticojejunostomy and gastrojejunostomy. Next slide, please. So why minimal invasive? We all know that it reduces the surgical trauma. There is a faster functional recovery because the incisions are smaller, less blood loss, lower wound morbidity, and reduced pain. Next slide, please. Why minimal invasive? Because robotic surgery, because of the 3D vision and magnification and movements of the wristed instruments, makes the job very easy in difficult angles and in space where there is a difficulty in moving our laparoscopic instruments. Also, because there is a faster recovery, you can give chemotherapy much faster. Coming to the learning curve, as you see here, the proficiency in doing pancreaticoduodenectomy is much, much faster in robotic surgery. You can see that, you just require 50 plus cases to reduce the operative time from 620 minutes to 380 minutes. And if you have to divide your training in different phases, phase 1 is, where you do the case selection, port setup, mobilization in first 20 cases. Phase 2, where you do independent dissection and you refine the reconstruction sequence, is between 20 and 40 cases. And after 40 cases, you think you can do all complex kind of cases. Next slide, please. So, stepwise case selection, mentorship, proctoring. Next slide. Please keep clicking. Ada, can you click, please? Yeah. Simulation video based training is very, very important today. In dry lab, you can do anastomotic drills, you can see videos, you can ask your videos to be reviewed by senior people. Next slide. Yeah, another one. Yeah. So by doing all this technique, by practicing, you can standardize your operative sequence, you can track your outcomes, and you should always have a low threshold for conversion, because our idea is not to harm the patient, but to make sure that we are able to deliver what we have promised our patient is a safety. Follow the oncological principle and make the procedure as safe as possible. Next slide, please. So these are some of the literature available, advantages and between laparoscopy and robotic. I will not go into the detail. What it shows is that in most of the steps, robot helps a surgeon in navigating difficult steps and delivering a safe procedure which can enhance the recovery, reduce the trauma to the patients. Accept higher cost and slightly higher time initially, but gradually, as you become more and more experienced, the time factor is almost equal. But yes, the cost of the procedure is higher. But if you see the cost to the patient in terms of early recovery, early return to the work, I think it's difficult to compare, and I would think that it is better than any other technique. Next slide, please. As I said, ensuring oncological clearance is the main goal of this procedure. MIS technique should never compromise the principle that govern the curative pancreatic cancer resection. Next slide, please. Another click. So the aim is to ensure R0 resection by doing meticulous dissection. We must standardize the lymphadenectomy. In difficult situations where we need vascular reconstruction, artery first approach is sometimes much, much better. And obviously, we should remove the tumor by no touch technique and follow all oncological principles. Next slide. So, when we say that we need to standardize the technique to protect the margins, what we need is we first do a diagnostic and staging laparoscopy to exclude any liver metastasis. Then we do uncinate or SMA first dissection to confirm the resectability. We need to skeletonize the vessel circumferentially, and then we do lymphadenectomy and en bloc removal of the specimen. We can send the margin for the frozen section and make sure that they are not positive before proceeding towards reconstruction. Next slide, please. So, pancreaticojejunostomy is the Achilles heel of any pancreaticoduodenectomy procedure. Ductal mucosa type is the one which was popularized by Bloomgard, and this is what we follow most of the times. Sometimes, if there is a high risk pancreas, that means soft pancreas, pancreatic duct is less than 3 millimeter. We what posteriorly placed, we do the invagination technique, and by robot we have actually the procedure, the anastomosis actually become easier as compared to laparoscopy. Next slide, please. As I was saying, that high risk pancreas is a soft gland, small duct size less than 3 millimeter, high blood loss, or pathology is non adenocarcinoma, ductal adenocarcinoma. Next slide, please. So we need to make a tension-free, well-vascularized jejunal loop alignment, and we sometimes in a smaller duct we can put an external pancreatic stent, and we may put a closed suction drain, early enteral nutrition, structured grading to guide the escalation of care, and low threshold for image guided collection for by percutaneous method, and multidisciplinary huddle for grade B, grade C fistula management. Next slide, please. Outcomes, what we find that median lymph node should be 15 or more. We should be, we should have done around 40 plus cases, and 15 to 20% chances of pancreatic fistula, and negative margins are found in around 85% of cases. And if you see the hospital stay in some of the series, it ranges in open surgery from 11 days to robotic 7 days. So there is a definitely advantage in minimal invasive technique. Next slide, please. Coming to the major complications, post pancreatic hemorrhage is one of the complications which can happen, and one should be very, very careful. There are different grading A, B, C. I will not go into the detail of these gradings, but this is important to understand so you can treat the patient well. Next slide, please. These are the potential bleeding sites: GDA stump, tributaries of major veins and arteries, branches of SMA, pancreatic cut surface sometimes can bleed, gallbladder fossa, suture line or staple line from either GJ staple line, pancreatic jejunostomy or jejunojejunostomy, and area of resection, which is a retroperitoneal raw area, can also do that. Next slide, please. Pancreatic leak and fistula again can be of different types. A, B, C. Grade A is biochemical leak. Grade B is well-defined fistula, and pancreatic fistula C is where you need intervention. Next slide, please. Next slide. Yeah, this is a video, as you can see here. I think this video is not working, madam. Ada, I think we will. I think it is very jerky. Can you stop it at a moment? For a moment, please. Ada,
Hello.
Ada, can you hear me? Can we take the question and answer now?
Yes, sir. Thank you so much, sir, for this wonderful presentation, sir. So, with all your permission, I'm going to take a question. So, the first
Questions
question
now?
is, yes, sir. So, the first question we received, sir, what does the current evidence suggest regarding oncological outcomes, post operative complications, and long term survival when comparing minimally invasive and open Whipple's procedures?
So at the moment, there is no oncological survival benefit in minimal invasive surgery. We have short term non oncological benefits in terms of faster recovery, less blood loss. As far as oncological results are concerned, they are similar to open technique.
Okay. Okay, thank you so much, sir, for this brief answer, sir. I hope you will justice. So the next question is, sir. The question is, sir, despite its advantages, sir, the procedures remains technically demanding. So, what are the biggest challenges surgeons face while performing minimally invasive pancreatic duodenectomy, sir?
So when we do robotic, I think there is we have to divide minimal invasive in two parts. One is laparoscopic, one is robotic. When we do laparoscopic, the challenges are in reconstruction. When you do
Yes,
pancreatic or
sir.
cystoscopy, it can be very, very challenging. But when you do robotic surgery, I think that challenge of reconstruction is made very, very easy with the help of robot. But yet, I would say that pancreatic duodenectomy itself is a challenging procedure and we should not take it lightly. Each and every step is very, very important and one should be very, very careful. Do not get overbogged by the enthusiasm of doing it robotically. You have to be very, very careful at every step.
Okay. Okay, thank you so much, sir. So the next question is, sir, how important, sir, is surgeon for experience institutional volume or multidisciplinary teamwork in achieving successful outcomes?
See, any any procedure, I would say, any complex procedures requires a good experienced team. There is no debate in that, and it has been proven again and again by literature that people who have a high volume practice are likely to give better results in terms of safety, in terms of complication, in terms of recovery. And I think that is an important point to understand, and everybody needs to train themselves properly and in a high volume center. As far as multidisciplinary team, as for oncological purpose, I think it is very, very important to remain within the guidelines, to follow the oncological principles. So today we are talking about multidisciplinary treatment of cancer, especially GI cancers, where radiation, chemotherapy, immunotherapy, surgery, most of the times more than one technology is used. Sequencing of this technology, whether surgery requires first or whether the neoadjuvant treatment is required and the surgery is required later, or vice versa, is something which, if you have a multidisciplinary board, will really help you in planning your treatment. So it's important, very important.
Okay, thank you so much, sir. So the last question I can see, sir, what message, sir, would you like to share with young gastrointestinal surgeons regarding the training or patient selection and the future of minimally invasive pancreatic surgery, sir?
I think future of minimal invasive surgery for pancreatic cancer is here to stay. There is no doubt about it. For younger people, they need to find a place where they can train themselves and they can understand the nuances of a procedure. They can understand the pathology of a disease. They can understand the biology of the disease, this, which will help them in choosing the right kind of patient. Whenever you are doing robotic surgery for pancreas, pancreatic cancer, I think in the beginning it is important to choose periampulary, small, completely sort of resectable cases on imaging, so which will help them in understanding the anatomy, and it will give them confidence to proceed to more complex procedures.
Okay. Okay, thank you so much, sir, for sharing your exceptional expertise and a valuable insight, sir, on minimally invasive Whipple's procedures. Where do we stand, sir? So, shall I conclude the session, sir, with all your permission?
Absolutely. Thank you so much, Ada, and thank you, IJCP.
Okay, you're welcome, sir. So, today's discussion highlighted how technological innovation, surgical expertise, and evidence based practice are redefining the future of pancreatic surgery. So, while minimally invasive Whipple's procedures offer promising benefits, their success depends on appropriate patient selection, advanced detailing, training, and a multidisciplinary approach to care, sir. Your insights have provided valuable guidance, sir, for our clinicians and doctors and surgeons striving to deliver safer, more precise, and patient centered surgical care. So, on behalf of IGCP, sir, I extend my heartfelt gratitude to you, sir, and to all our participants for joining us today, sir. Thank you so much, sir, for being a part of this session, sir. Have a wonderful day, sir. Stay informed, and
Thank
we
you.
look forward to welcoming you to another IGCP series, sir. Thank you so much, sir.